Next case is a 74-year-old gentleman with a past medical history of benign prostate hypertrophy. He was recently seen in medical clinic for weight loss, and this time presented to us with epigastric pain and deranged liver function test. An ultrasound showed a dilated 11 millimeter CBD stone with isodense material in the CBD with suspicion of sludge or stones. And the gallbladder was also impacted with stones and sludge as well. We attempted an ERCP, but the major papilla was very floppy, also partially obscured by the overlying duodenal fold. There was also difficult access, therefore we failed a CBD cannulation. A diagnostic EUS was done with the proximal CBD diameter of 9 millimeters, small stones and sludge seen in the distal CBD, and stones and sludge were also seen in the gallbladder as well. This is the endoscopic image of the floppy major papilla and the EUS image of the dilated CBD. So today we will proceed with the EUS rendezvous ERCP performed by Professor Tang.
Good afternoon, Raymond.
Hello, hi Tang. Hello.
Hi. Okay.
I have Marc with me here.
Yep.
This patient actually has a recent ERCP for cholangitis. We found some stones and sludge. We failed cannulation due to a difficult access. So my scope is already in the
Can you show us the stone?
Well, it's not big stones. No, but I don't want to really move my scope because I'm trying to really focus on putting the bile duct in a good position. But I'll give you a try out here. Oh, yeah, here. Can you see?
Okay.
See a stone there. Okay.
Very small one.
Yeah. So yeah. So you see a stone. Now, but then now I have to change my scope position back to a suitable position for the ESRV. So here you can see the portal vein there. Maybe Marc can help me. I have Marc with me today. So we perform ESRV for difficult cannulation. But the prerequisite is we want to see if the bile duct is dilated enough. So we have the bile duct here, and then let's see the diameter. Oh, X-ray capture. Okay. Okay. Oh. So not super dilated, but I think probably will be okay for the procedure. So.
Raymond, one question. For this kind of case, would you prefer a pre-cut on the papilla or the rendezvous technique?
Yes, so that's a very good point. So for conventional advanced technique for ERCP, so we definitely have the option of pre-cut. So there are three kinds of pre-cut we can consider. One is freehand needle knife pre-cut starting from the orifice of the papilla, or fistulotomy, or a transpancreatic pre-cut with a sphincteroscope. But what was difficult the other day was there was an overlying fold on the papilla, as you may see from the presentation. And then also the access was quite difficult. And so far, the sphincter cannot sit into the common channel very well for transpancreatic pre-cut. So we think that maybe RV is a possibility here, but probably maybe an easier option than the pre-cut. So that's why we have him here today. So, but I think a couple of things besides checking the size of the CBD, we will try to optimize the scope position so that we have a better chance of getting the wire down. So in this case, for the long scope position, the needle could be pointing up to the hilum, but I guess I'll try to find a window that is suitable for the puncture, and also we'll use the angle wire. And usually, we'll try to ask Marc and also a doctor to help if there's difficulty getting the wire out of the papilla.
So yeah, for RV, I think first of all, of course, the indication we want to know what pathology we're dealing with, and also we would like to know where we want to perform the puncture. Here we're doing it in the D1. Yeah.
So this is the best position you want to achieve for your scope?
Well, we did EUS the other day. We tried the short scope position, but the difficulty is the needle will be pointing at the stone itself. So then actually also a problem. because if we have a trajectory that will actually hit the stone, sometimes it may be a very problematic actually. And the distal duct sometimes tend not to be very dilated.
So what needle are you using?
I have a 19 gauge Olympus EC short free needle. I think it's helpful because it's a very sharp needle and the tip is very echogenic, so quite easy to visualize. So now I'm trying to find a position. Let's put on a Doppler. Now we're going to see.
Usually after we mount the needle, the wheel may be a little bit different, so I think that here is not bad.
Yeah, it's not bad here. So now we see quite obvious dilation, but of course I try to see if I can get the vessel out of the way. Now you can see maybe a little vessel. Now here is better. Can you hold this position? Now hold your hold your.
So during the US view, we focus on the like 1 or 2 o'clock where the needle will come out, and try to avoid any vessel that would otherwise be getting in the way.
So my needle is coming out, and then now hold your. Hold your. Now so I should be in. Now we can inject a little bit contrast here. Yes, so a duct here. No, hold on 1 second.
Yes.
No, but then actually not fully. I may have to. This may be still some submucosal injection. I may need to repuncture here. So what happened is that the needle hasn't fully traversed the area. Okay. Now, so can you do a Doppler again?
Sometimes it can be difficult, especially when the duct is not very dilated.
As it seems that you have got a cholangiogram.
Yes. And
Is your guide wire in?
Yes, guide wire in. Now we are trying to get the guide wire down. Now
Can we enlarge the
endoscopy.
fluoroscopy?
Fluoroscopy. Enlarge the fluoroscopy view, please.
Yes.
Yes.
Thank you.
So eventually we did another puncture, and we, after confirming position, inject contrast and bit of NS to make sure we have enough space to work. So now the wire is well inside the CVD, and we are trying to get it out through the major papilla.
How do you get the wire going down? It seems that your needle is pointing up.
So we use an angle wire.
Okay.
Now we are getting down to the papilla level now.
I think you are in duodenum.
Yes. So now I'm trying to confirm. I think I came out, but then I want to confirm.
I think the key in trying to get the wire in the right position is when it goes out of the needle, try to spin it instead of just pushing out. And so it can somewhat help with the direction, and try not to blind and advance too much, because if you pull back, there's also risk of wire shearing.
Yes. So I think now here we have a more reliable wire trajectory. Now can we take a save? So sometimes it takes a little bit work. In this case, I think the challenge is the duct is not as dilated. Sometimes it's a good thing, because if the duct is too dilated, we may have trouble getting the wire out. Now, I'm going to hold the scope. Maybe I'll let Marc help me with the wire. It's hard for me to do everything here, so no. Spin. Yeah.
How do you prevent the shearing of the wire while you're manipulating?
Yes. So now I have to watch out for the. I have to watch out for the. I have to really watch out so that the wire is not having high resistance at the baffle, because. But why I picked the needle? Why I picked the EC short free needle is because the baffle is a little wider, so it's good that wire shearing can be less. Now, but here I would say that even though I think the wire is in the distal CVD, but I cannot say for sure that the wire has come out yet. But I would like to see more wire in the duodenum. But I think probably I'll work on it a little bit just to confirm.
And sometimes some minor needle manipulation may help to prevent wire shearing.
So I'm trying to
So are you satisfied now?
probably I would like to see more because sometimes the wire can get dislodged if we're not careful. So yes. No, so and sometimes it's good to have another person to help with the wire. No, now, and sometimes we can add the talking device to the wire. So sometimes it's now let's try the talking device too. So now, the wire actually, as Dr. Leung said, I think the wire actually was already out, but we were just a little worried. It doesn't have long enough length. So that's why we want to push out a little bit more wire, as you can see. Now, we're in duodenum. And then the RV wire is here. But as you can see, the papilla position is still difficult. Because
I cannot see the papilla
underneath the
yet.
fold.
yeah.
So
But-
where's the papilla? Can you show us where
Yeah,
the papilla is?
trying to get to here. Now, the RV wire has already come out. Can you see the wire? No. We may need some glucagon or buscopan. So the RV wire is right in front of us. And I'm trying to get you a better view. Now, can you see
Yeah,
this papilla?
we can see that now.
So it's obscure, very difficult for pre-cut. So what I'm trying to do is I'll start with trying to cannulate alongside first, if possible. And if I can do that, I don't need to grab the wire.
People do modify the cannulum to make it a trough to follow the wire.
Yeah, that's a hitch and ride method. So it's also good. Now, but it may be difficult. See why? 0.5頂唔頂啊？使唔使啊？使唔頂 ？Okay. Now, so still a little difficult here. Now, see here. Now
So-
I got the wire.
What do you use to grab the wire?
So this is, we have a few options, either a snare or forceps, alligator forceps, or this is a loop cutter. So I learned this technique from Japanese colleagues, and then they think this is a very good grasping device. So the goal is, of course, not to cut the wire, but is to grab it firmly so that it won't slip off in the channel. So now I'm ready.
So the
to-
assistant is very important.
Yes, of course. So we have a good assistant here. So nurses,
Strong enough to grip the wire, but not strong enough to cut it.
Exactly, exactly. So now we're going to try to now get the wire into the channel. Now I'm going to do it slowly.
Yeah. So
it may
your
be a
assistant
little
is
tight.
pushing the wire in.
可以放返先。嗱，係啦。It may be a little, I may be grabbing a little too much, so I may need to go down a little bit now. So I asked Marc to pull back the wire a little bit.
You try to grip the
Yes.
soft part of the wire.
Yes. So now gentle pull back.
So I'm trying to pull back the wire gently so that Raymond can get access to the most distal tip part of the wire, which
Yes.
is easier to grab.
Now slowly, so there's delay. Now, so there's always a delay in the wire movement. So I'm looking for the yellow portion, or the green portion. No. So I'm keeping an eye on the X-ray. Now it's coming in. I have to be very careful. So now, slowly pulling. Now it should be coming in. Now stop. Now, so
Yeah.
I'm going to look for, the partner siasana.
The flexible end.
Okay, yeah. Click. So I'm still looking for it now. Slowly pull back. Slowly pull back. Slowly. Now there's a delay, so slowly. Now, okay. Now, so can show. Now, so coming in. Now, okay. We have the wire out of the scope channel already. We are getting enough length of the wire to backload the sphinctertome. So we are working on that. Now, we don't want to pull too hard on this rendezvous wire. So, but we still have some work to do to get the wire into the sphinctertome. So as you can see, now we are backloading it. So we still have some work to do. So the plan is once we backload the sphinctertome, we will confirm access, and then hopefully we'll retrieve the wire totally into the bile duct, and then we will put the sphinctertome deeply into the bile duct, and we will reverse the side of the wire so that the sharp end won't be in the bile duct.
So Mark is holding one end of the wire,
Yeah, he's giving me
and then
wire.
the nurse is holding another end.
Yes.
So you will not lose any track of it.
Yes, that's very important. Yes. So now, so let's back low. Let's continue the back low.
So we need a very long guide wire in this case.
Yes.
Yes.
So
so-
what kind of guide wire you're using now?
We have angle tip 0.025 VC glide. So this kind of one of my favorite wire for US rendezvous technique or the US guided beery drainage. It has a very good talkability if I need to negotiate through stricture or some angulation, and sometimes even getting through stones or papilla, it will be very helpful. So but the special thing about the wire is it has the same stiffness as a regular 0.035 wire. So I don't need to change to a different wire, and I can do stenting or therapy directly. So now another way to do this is if, for example, we are concerned that the wire is not long enough to pass through a long wire system sphincterotome, now we can use a rapid exchange sphincterotome so that we'll grab the wire and then get the sphincterotome up. So we are getting that right now. And so Tang, I know you also do a lot of US. So can you tell us a little bit? What are your thoughts on the RV and and any things that you want to share? With
I
the
never
audience?
use US guide RV.
Yes.
I never failed.
Very nice. That's good. No,
So sorry.
Yes. Very nice. Very nice. Very nice. So, but
Just
I think,
joking, sorry.
Yes.
I think in the private, you can't fail in the private.
Yes.
Just joking. Just
Yes.
joking.
We work in the public, so we can fail.
Yeah. I think for us, this one is a difficult papilla to do the pre-cut because it gets obscured by the fold.
Raymond, what do you think some people advocate, like clipping the fold to expose the major papilla before we try the cannulate?
Yes,
so sometimes you can cut on the fold as well. That's just overhang mucosa.
yes.
You
Yeah,
cut
so-
it and it won't cause a perforation.
Yeah, because Dr. Leung, sometimes I was a little kind of unsure, how much I can do that, how much I can. Can you tell us a little bit how you would approach?
Well, can I have a good view of the papilla first? You put back the scope, then we can see the papilla.
Raymond, one expose the papilla.
Yes,
That's good.
You are very careful in advancing the sphincterotome.
Yes. So, we're waiting for the rapid exchange system.
Yeah,
Sorry.
you can see that there's an overhang fold on the
Yeah.
over the papilla, but the papilla, I think, is around. You can see the first fold and then the second fold. I think the papilla is around the top end of the second fold, so it's safe at least to cut on the first fold.
Yes. So, but sometimes I have a difficult time too. So, but do you like to do clipping of the fold? Do you have any tips for us?
Just cut it, and then
Just cut it.
and then you can see the muscle of the sphincter,
I see.
and then you can cut on the muscle.
Yes. Yes. Or maybe we'll also ask YT. I mean, what is your preferred method for the pre-cut?
Just free hands.
Okay.
Usually along direction, and you cut it and you'll get it.
So yes. So sorry, a little embarrassing. Still finding the rapid exchange system because here we rely quite a lot on the nurses, and nurses are good, so we have the long wire. So
Possibly we need to close the live demonstration section.
okay.